This morning, we heard the presentation about how to improve the skills of general practitioners, management-wise, money-making-wise, and my presentation is how to improve the team. Money-wise, of course, that will come, but making the general practitioner a master clinician and a master diagnostician with the help of the dental hygienist. So this presentation target is both the general practitioners, there are about 130,000 of them in the United States, and there's only about 33,000 specialists. I am focusing on making a better general practitioners. This is what we see. The team of dentistry, the front office, the back office, the coordinators, and the dental hygienists have one objective. You all talk about mission and vision, that everybody must have and share the same vision, same mission. Their job is to make it possible for the general practitioner to be a master diagnostician, a master clinician, by freeing him to have more time to treat patients, not to waste time on menial jobs. I've been in education for 50 years, and that has been my goal in graduate endodontic education and advanced general dentistry education, to make the master diagnostician, to make the master clinician. And how we do that? By accumulating the experience, by having evidence-based diagnosis, evidence-based treatment methodologies. Once you are a master diagnostician, then you are a candidate to be a master clinician. And how you do that? By being a diagnostician, number one, and have a right-hand person, a dental hygienist dependable that you could trust, and a trained dental team. Why? I'm Dr. Abou-Rass. I'm an endodontist by training. I have a master's in prosthodontics. I have a PhD in educational psychology. Why I'm interested in this? Why I'm talking about dental hygiene education? It's because of this. A couple of years ago, we were in Anaheim attending a meeting, continuing education meeting. And in that meeting, I was approached by a dental hygienist. My niece is a dental hygienist. She said to me, Dr. Abou-Rass, please, could you take a look at this x-ray? This patient, the dentist said, root canal should be retreated. What do you think? I looked at it, substandard. I said, definitely, the dentist is right. She said, but why? Patient has no pain. There's no lesion on the x-ray. I said, we need to retreat anyway, because that is a standard of care. And once you retreat, you will find problems, you find things you did not expect. Endodontic failures on bad root canals is a failure in fermentation, in process. But anyway, what about the tooth next door? The molar next door has cervical aggressive resorption. She said, no. This is going to be caries, root caries. The dentist said he is going to do a filling there. I said, no, whatever. When I heard that, I've been in education so many years. She went to a good dental school, but there's something wrong. Why is it wrong? I said, I must investigate what's wrong with dental education of dental hygienists. I searched these master textbooks. These are the mothers of all books in dental hygiene education. I went through 300 program outlines in the United States and Canada on what does a dental hygienist learn about endo, about resto, about the relationship between endo, perio, and resto. I was surprised. I was impressed what I found. I found a tremendous progress from the traditional role of dental hygienist, tooth cleaner, oral hygiene instruction giver, to something much bigger. In the United States of America today, in Canada, there are competent, very competent clinical dental hygienists. They are prevention program directors. They teach dental hygiene. At USC, where I came from, they even teach courses in perio. They are the prevention specialists in the dental office, especially when it comes to caries and periodontal disease. They are the screeners of oral cancer. They are acknowledged for that. They are fantastic when it comes to the relationship between perio and systemic diseases. However, when I finished the review, I was very surprised. What I found, weakness, shortage of information about endo the way we do it today, shortage about information about restorative dentistry criteria the way we do it today, and the most important finding, the dental hygienist is underutilized in American dentistry. The dental hygienist is a human resource, incredible human resource that has not been discovered in American dentistry. I am not talking politics, I'm talking clinical. And that is basically my purpose today. And why? Because most of you heard, and especially of you who are dentists, know that endo, perio, and resto are the foundation of general practice everywhere in the world. Ortho and other specialties are there. But the point is, the dental hygienist and the dentist must every single day see patients with these three triad problems. And then if we look at the American Dental Hygiene Association, the American Dental Education of schools, look at the process, the dental hygiene process of care. The first and second step is what? Identify the problem, collect the information, diagnose, diagnose, and diagnose. How could the hygienist diagnose only perio and prevention? That's not right. Actually, it's dangerous. How could they ignore dental pulp diseases, periapical pulp diseases, the endoperio disease? Can a hygienist differentiate between the pulp chamber on the left and the pulp chamber on the right? One is a healthy one, the other one is actually dying one. It's calcifying one. A dental hygienist must know that when they do a SRP. Can a hygienist really know the difference between a good endo and a bad endo? Do they know why we must retreat? Can they differentiate between a good post on the left side and a bad iatrogenic post on the right side, actually cracking the tooth, actually causing periapical pathology? And then when it comes to restorative dentistry, can the hygienist know that on the picture on the left, that molar, that discoloration of the margins is one of the most serious problems in dentistry, coronal micro leakage. Underneath that bad restoration, you have a very dying pulp or inflamed pulp or whatever. There are implications for this leakage, endo implication and perio implication. Do hygienists know that when the tooth changes color, when the tooth is changing color could mean a dying pulp, a calcifying pulp, a failing root canal, a bad root canal, a periapical abscess? This is information the dental hygienist must know every single day. Next, underneath that amalgam cracks, lower left, the malpositioning of teeth, 100% periodontal implications, and so on and so forth. My purpose is the dental hygienist becomes the primary source of patient preventive and diagnostic information in general dentistry. My purpose, that the first impression, the first impact, the dental hygienist is the first patient, first clinical encounter in the general practitioner office. She collects, or he collects, all the diagnostic information, all of it, and educate the patient, explain the problem, motivate and prepare them for follow-up treatment by the dentist. She is, or he is, the dental hygiene, the liaison between the dentist and the patient. And actually, the dental hygienist is truly the right hand of the dentist. For that purpose, I made the Masterclass Series on dental diagnosis, courses, the first unit on limitation of conventional testing, the second unit on teaching the 4-hour protocol, the third unit on 7 reasons how difficult pain, and the fourth one on root resorption, and the fifth one on diagnosis of periapical imaging in endodontics, and the sixth one is the most important, the dental warning signs, the tip of the iceberg. This color change is the tip of the iceberg. The iceberg is the endo problem, the peria problem, and that's called the warning signs, and I thank you for listening.